Welcome to the Deep Dive, the show where we take a stack of dense, often crucial information and turn it into the knowledge you need without the headache.
And today, we are really taking on one of the, I think, great remaining public health challenges in oncology, lung cancer screening.
But, and this is the important part, we are not talking about the historical paradigm, not the one that's laser-focused on heavy smokers.
No, not at all.
We are dialing into a demographic that has, for a long, long time, been dangerously overlooked by global health models.
It's a truly critical pivot in cancer research. I mean, for decades, the global consensus has been so simple, right? Smoking equals lung cancer risk.
Right. It's almost a one-to-one association in the public mind.
It is.
Yeah.
And while that link is overwhelmingly true in places like the US and Europe, the moment you look east, that fundamental assumption, it completely fractures.
And here's the reality, the statistic that really defines the problem we are unpacking today. In Taiwan and in many parts of Asia, more than half, we're talking 53% of patients newly diagnosed with lung cancer are never smokers.
They have never picked up the habit, ever.
This isn't some small minority group. This is the majority of diagnoses.
And that statistic, it becomes even more shocking when you stratify the data by gender.
Oh, absolutely.
Among female patients in Taiwan, that figure jumps to an astonishing 93%.
93%.
Think about that for a moment. Almost all women diagnosed with lung cancer, there are women who have avoided the single greatest risk factor we in the West screen for.
And furthermore, and this is the real public health urgency driving this, the majority of these never smokers, nearly 60%, are being diagnosed far too late.
Far too late.
At stage 4 disease. And this happens because our traditional Western screening paradigm, which, overwhelmingly prioritizes heavy smokers with 30-plus pack years of history.
It completely misses them.
It completely misses this massive high-risk group.
Exactly. The existing global screening models, which are designed to catch smoking-related cancers, are simply not fit for purpose when you're faced with this genetically and environmentally distinct lung cancer profile. The current strategy is failing half the world's population.
Okay, let's unpack this. We're taking a deep dive into how genetics and environment combine to create a distinct lung cancer risk profile in a huge segment of the population that's often overlooked.
And our source material for this is really foundational.
It is. It's the research from the Taiwan Lung Cancer Screening in Never Smoker Trial, or TALENT as it's known.
This isn't just a small study. This is a massive nationwide multi-center prospective cohort study designed from the ground up to solve this very problem.
So the goal of TALENT, what were they setting out to do?
The goal is straightforward, but its implications are vast. It's to determine the efficacy of low-dose CT, or LDCT, screening among never smokers who have other non-smoking related risk factors.
So it's not just about proving that this population needs screening.
No, it's much more than that. It's about scientifically identifying the right people to screen and, crucially, understanding the non-smoking drivers of this disease.
This research stands to fundamentally change global screening recommendations, especially for populations of Asian descent, well, worldwide.
Absolutely.
So to truly appreciate what TALENT achieved, I think we have to start by looking at what was failing.
Right. The old way of doing things.
Yeah, exactly. Traditional Western screening trials, like the big ones, the U.S. National Lung Screening Trial, NLST, or the European Nelson study, they defined high risk based on the primary American and European driver, heavy tobacco use.
Mm-hmm. We're talking 30-pack years or more, a lot of smoking for a long time. That was basically the entry ticket to get an LDCT screening.
And that definition is statistically sound for those populations, where smoking is the overwhelming cause of the cancer.
It is. But when researchers looked at the incidence in Taiwan, they realized they couldn't just copy and paste those criteria. It wouldn't work.
Why not? What would have happened?
Well, if they only screened 30-pack year smokers, they would miss 9 out of 10 female patients.
Wow.
And over half the male patients. The model just doesn't apply.
So TALENT had to completely rewrite the playbook. They had to redefine what high risk even meant for a never smoker.
Exactly. Their hypothesis was that, in the absence of heavy tobacco carcinogens, something else must be driving the risk.
Something had to be amplifying it.
Right. And they bet on two things: genetic susceptibility and specific intense environmental exposures.
So the endogenous factors, the genetics, and the exogenous, the environment.
Precisely. They recognize the drivers are just fundamentally different.
So let's get into the details as who they enrolled, because this is where the study's hypothesis was really put to the test. The TALENT trial was massive.
Oh, huge. They enrolled 12,011 participants across 17 different medical centers in Taiwan.
In the core demographics.
The main age group was 55 to 75 years. But, and this is a really important detail when you're looking at inherited risk, they allowed exceptions for younger participants, specifically people aged 50, 54, or even younger, but only if they had a very strong family history.
Ah, so they were already biasing the study towards finding hereditary cancers.
A clear early bias, yes. They were actively hunting for those hereditary, possibly early onset cancers.
And before they even got to the high-tech LDCT scan, there was another step that made this study different, right? The pre-screening.
Yes, that's a key methodological point we really have to acknowledge. It's important. All participants were required to have a negative chest radiography pre-screening.
A standard X-ray.
A standard chest X-ray. And what that means is that any tumor that was large enough or advanced enough to be visible on that X-ray was automatically excluded from the study.
That seems like a smart public health decision. I mean, why waste resources on people who already have visible disease?
It is smart. But what does that exclusion do to the final results when we try to compare them to, say, the NLST or Nelson studies, which didn't usually have that requirement?
Right, it's not an apples-to-apples comparison anymore.
Exactly. It creates something we call a stage shifting effect that's a little bit artificial when you compare them head-to-head.
How so?
Well, because the bigger, more obvious stage 2 or 4 tumors were already removed from the pool, the LDCT screening was inherently going to find a higher proportion of smaller, earlier stage tumors, the ones that were still invisible on that X-ray.
Okay, so we have to keep that in mind. It's an important factor when we get to their incredibly high rate of early stage detection later on.
A very important factor.
Fair enough. They were screening a population of people who appeared healthy on a basic X-ray. Now, let's define their target group, the never smoker category. How did they define that?
The definition was pretty stringent, but it did include a small amount of flexibility. The source defined it as having never smoked, or being a light ex-smoker.
And how do they define light ex-smoker without, contaminated the never smoker cohort with that traditional tobacco risk?
They set an extremely low bar, someone who smoked fewer than 10 pack years.
So very light smoking.
Very light. And crucially, they had to have quit more than 15 years previously.
Okay, so the risk has had time to diminish.
Right. The research team considered these individuals basically similar to pure never smokers because the risk reduction from quitting becomes so substantial after 15 years for such light smokers.
And how many of the cohort were pure never smokers?
The vast majority. 93.3% of the cohort were pure never smokers. So they really did successfully isolate the demographic they were targeting.
The crucial component then was the selection based on what they called the other factors. You had to have at least one of these non-smoking risks to get in. So what were the 5 factors they decided to test?
These factors were a combination of genetic and environmental hypotheses really specific to Asian populations.
Okay, what was the first one?
First, and they deliberately oversampled this group, was family history of lung cancer going out to third-degree relatives.
And when you say they oversampled?
It was heavily weighted in the enrollment. 6,009 participants. So exactly half of the total 12,011 had a family history. They intentionally biased the cohort to really, really study this genetic factor.
Okay, so genetics was front and center. What were the other 4?
The remaining 4 were environmental risks, often cited in regional studies. There was passive smoke exposure, which was, almost ubiquitous. 82.6% of participants reported it.
Right.
Then a history of chronic lung diseases, specifically pulmonary tuberculosis or COPD. And finally, the 2 factors related to kitchen air quality and cooking.
This is the part I find so interesting.
Yes. They looked at a cooking index of 110 or higher, and then also just cooking without using ventilation.
I think we need to linger on that cooking index because it's so specific. You mentioned it's like a pack year equivalent for cooking fumes. Can you break that down?
It's an incredibly detailed attempt to quantify cumulative exposure to carcinogens created by high-heat cooking, the kind of cooking that's really common in Asian cuisine.
So stir-frying, deep-frying.
Exactly. Pan-frying, stir-frying, or deep-frying. These methods generate ultrafine particles and polycyclic aromatic hydrocarbons, PAHs. Nasty stuff.
And how did they calculate the index?
It was calculated by multiplying the frequency of cooking by those high heat methods up to a maximum of 21 times per week. by the total number of years the person had been cooking.
So someone who's stir-fried twice a day for 20 years would easily hit that 110 threshold.
Oh, easily. It's an attempt to measure long-term, high-intensity exposure to a known airborne carcinogen source, but one that's inside the home.
And what percentage of the group met that criteria?
About 36.6% of the entire cohort met this threshold. The researchers were really trying to see if, after controlling for genetics, this chronic indoor air pollution was the independent driver of lung cancer in this group, just like tobacco smoke is in the West.
That makes perfect sense. So once the 12,011 high-risk participants were enrolled, what did the actual LDCT schedule look like?
The protocol was very pragmatic. It was built for long-term health system planning. Everyone got a baseline LDCT scan.
Okay, year zero.
Year zero. Then, recognizing that most cancers in screening trials are found in that first scan, they followed up with an annual scan for the first 2 years.
So year one, year two.
Right. And then they shifted to a biennial schedule. So every 2 years, up to 6 years. The total planned follow-up is for 8 years.
So it balances finding cancers with not overscreening or overspending.
Exactly. It balances efficacy with the need to manage healthcare costs and resource allocation.
And finally, for the parameters, how aggressive was their definition of a positive scan? Were they looking for tiny things?
They absolutely were. The LDCT positive definition was very sensitive, tailored to catch these often non-solid, very early cancers.
So it triggered a follow-up.
A positive scan was defined as a solid or part solid nodule larger than 6 millimeters, or a pure ground glass nodule, a GGN, that was larger than 5 millimeters.
So they were casting a very fine net.
A very fine net specifically for these subtle, slow-growing, pre-invasive lesions. They weren't waiting for them to become big, obvious tumors. They were hunting for the slightest sign of change.
All right, so let's jump into the results after that baseline scan in the first year of follow-up. This is the moment of truth. Did this new set of risk criteria actually identify a population that was, well, significantly diseased?
Oh, they did. Emphatically. The criteria worked, and it worked well.
What was the positivity rate?
At baseline, the LDCT positivity rate was 17.4%.
17%.
Yeah. That's 2,094 out of the 12,011 participants who had suspicious findings on their very first scan. That right there is a massive initial indicator that the non-smoking risk factors they chose, family history, age, gender, are really effective at homing in on high-risk individuals.
And let's look at the nature of those findings. In a traditional smoker's trial, you'd expect more of those dense, solid tumors.
Right.
Given this was a never-smoker cohort, did the distribution lean toward those more subtle ground glass lesions?
It did, and that confirmed the expected pathology for this group. It told them they were looking at the right thing. Out of about 3,000 total suspicious nodules they found at baseline, over half, 52.3%, were pure ground glass nodules.
The GGNs.
The GGNs, which are often signs of very early non-invasive growth, another 14.9% were part solid, and about a third, 32.8%, were solid.
So a fundamentally different distribution than you'd see in heavy smoker cohorts?
Completely different. And it validates the need for that sensitive, tailored, positive definition we just talked about.
That sets the stage for the most compelling number in the study. The overall lung cancer detection rate. After that first year, how many cancers did they actually find?
The overall lung cancer detection rate was remarkably high, 2.6%.
2.6%.
Which translates to 318 participants who were diagnosed with lung cancer in the first year alone.
Okay, we need context for that number. How does a 2.6% detection rate in a population that has never smoked compare to the detection rates in cohorts made up of heavy 30-pack year smokers?
And this is what's so fascinating. The overall detection rate in talent, that 2.6%, is significantly higher than the rates found in the heavy smoking Western cohorts.
Higher.
Much higher. The U.S. NLST, for example, detected 1.1% of lung cancers at baseline. The European Nelson study detected 0.9%.
Wait, so this study, talent, achieved a 2 to 3-fold higher detection rate, despite screening a population of overwhelmingly never smokers.
Correct.
So what does that mean? It means the combination of factors they used, primarily genetics and gender, are statistically more powerful predictors of lung cancer in this population than a lifetime of heavy tobacco use is in the Western cohorts.
That is the monumental finding. It's absolute validation of their hypothesis.
That's incredible.
And the breakdown of those 318 cases further clarifies the severity. The majority, 257 cases, which is 2.1% of all participants, were diagnosed with invasive lung cancer.
So the dangerous kind.
The dangerous kind. The remaining 61 cases were the non-invasive form, adenocarcinomas in situ, and importantly, 317 of the 318 cancers were adenocarcinoma, which is the signature tumor type for never smokers.
This success leads directly into the core objective of any screening trial, which is finding the disease early enough to be curable. How did CALENT do in terms of stage shifting?
The success here was, it was unprecedented. A huge 246 participants, that's 77.4% of all the cancers found, were diagnosed with stage I disease.
Stage I, curable.
Exactly. And if you include stage 0, which is that non-invasive adenocarcinoma in situ, that figure jumps to an astonishing 96.5% of all detected cancers being either stage 0 or stage I.
96%. To put that into perspective, how does that compare to the gold standard trials?
The difference is just striking. LST found 50% of cancers at stage I.
Half.
Nelson found 58.6%. Talent's high-risk criteria, plus the sensitive LDCT screening, essentially doubled the likelihood of catching the disease at stage I compared to many of those large-scale studies.
Now, let's revisit that methodological caveat. The chest X-ray pre-screening, does that artificially inflate that incredible stage I rate?
It definitely contributes. There's no doubt about that. By excluding those larger X-ray visible tumors, they were guaranteed to have a lower proportion of late-stage disease.
So it's not a perfect comparison.
It's not. However, even if you analyze only the invasive cancers found, and even if you try to adjust for that methodology difference, the rate of finding truly invasive stage I disease remains significantly impressively high. The stage shifting is real, and it demonstrates the potential for a massive reduction in mortality for this high-risk group.
So beyond the sheer number of cancers found, let's look at the diagnostic performance. How well did the screening tool itself work for this group? We're talking about things like sensitivity and specificity.
Right, and we should define these for you, the learner, because they tell us how reliable the test really is.
Okay, let's start with sensitivity and specificity.
The sensitivity was 92.1%. Sensitivity tells you, if you have cancer, how often will this test correctly say you have it?
So how good is it at not missing cancers?
Exactly. And 92.1% means the LDCT rarely missed a true cancer case. It was very sensitive.
And specificity.
The specificity was 84.6%, which asks the opposite question. If you don't have cancer, how often will the test correctly say you don't have it?
How good is it at avoiding false alarms?
Precisely. And 84.6% is solid. It indicates relatively few false alarms.
Now, for the two metrics that matter most to a patient, let's start with the most comforting one, the negative predictive value, or NPV. If my scan comes back clean, how confident should I be?
That's a fantastic question, and the NPV is where the good news truly shines. The negative predictive value was extremely high, at 99.7%.
99.7.
This is the metric that matters most for reassurance. It means if your LDCT scan is negative, there is a 99.7% certainty that you do not have lung cancer.
That is powerful.
It's a powerful reassurance for the millions of people in this demographic who might be anxious about their status. A clean scan is a very clean bill of health.
On the flip side, let's talk about the necessary evil of screening. False positives. How often does a positive scan turn out to be a false alarm? What's the positive predictive value, the PPV?
The overall PPV was 14.0%.
14%.
Now, 14% might sound low. It means 86% of positive scans required some kind of follow-up, but ultimately turned out to be benign. However, this is actually significantly higher than you often see in initial screening studies, which can sometimes drop into the single digits, so 14% is quite efficient.
And there was a key finding when they segmented that PPV based on the entry criteria, wasn't there?
Absolutely. The PPV was substantially higher for those participants who entered the trial, specifically because they had a family history of lung cancer.
So for the genetic risk group.
Exactly. For that group, the PPV was 17.0% versus just 10.9% for those without a family history.
So if your scan is positive, the odds of it being true cancer are nearly 50% higher if you have that strong family history.
Precisely. It really supports the initial hypothesis that family history is a powerful risk multiplier.
Any screening trial has to face the ethical questions about safety, unnecessary invasive procedures for benign findings. How did Talent stack up there?
The source data was very reassuring on safety. They monitored the procedure safety metrics very carefully. The overall benign invasive procedure rate, so biopsies or resections that found no cancer, was 19.8%.
Okay, so about 1 in 5.
And the rate for benign resections, so people who went all the way to surgery only to find a benign lesion, was 13.9%.
Keeping the unnecessary surgery rate below 14% is a really key measure of success.
It is, because it suggests the careful follow-up protocols they used were successful in minimizing harm. And critically, there were no reported procedure-related deaths in the entire cohort.
That's huge.
It validates the feasibility of doing this on a large scale, and it addresses those concerns about safety and unnecessary surgery, especially when you're finding these early, often very localized lesions.
Okay, so we've now established two major facts. First, the talent criteria successfully identified a high-risk population.
Yep.
And second, that LDCT screening works spectacularly well for finding early-stage cancers in that group. But this success rate is so high, it raises the million-dollar question, what was actually driving those diagnoses?
That's exactly right. Up until now, we've just been looking at correlation. Now we have to move to the multivariable analysis.
The statistical deep dive.
The deep dive, yes. This is the sophisticated process they use to isolate independent factors. It adjusts for everything at the same time to see which variables are the robust, independent predictors of invasive lung cancer risk.
Here's where it gets really interesting. So, out of the 5 criteria they use to enroll people family history, passive smoke, chronic lung disease, the cooking index, and ventilation, which ones actually survived this stringent statistical test?
Only 3 factors proved to be significantly associated with an increased risk for overall lung cancer and invasive lung cancer across all 12,000 participants.
Just 3. Let's start with the most powerful one.
The number one strongest independent predictor was female sex.
Wow.
The analysis gave an odds ratio, or OR, of 2.06 versus male participants.
Okay, let's pause and define what an odds ratio of 2.06 actually means in a conversational context.
Sure, an odds ratio tells you how much more likely an event is to happen for one group compared to another after you've controlled for all the other variables in the model.
So an OR of 2.06 means?
It means that women in this cohort were more than twice as likely, about 106% more likely, to develop lung cancer compared to the men, even when both groups had similar family histories and environmental exposures.
That is a massive risk amplifier.
It's huge, and it reinforces the necessity of tailoring these risk models specifically for Asian women. That factor, just being female in this cohort, is a primary screening criterion in and of itself.
That's incredible. What were the other 2 factors that remained significant?
Second was family history of lung cancer. That significantly increased risk with an OR of 1.67 versus those with no family history. So that validated the genetic hypothesis.
And the third?
Third was age older than 60 years, which increased the risk by a factor of 1.03 per year.
So the risk just ticks up steadily as you get older.
Exactly. It suggests the progression risk accrues linearly with age in this high-risk group, which implies these cancers are, in fact, progressing over time.
This is truly the core clinical finding of the study, because it tells us what really matters. But what happened to all the environmental factors? The passive smoke, the cooking, all those things they spent so much effort tracking.
That is the paradoxical cooking finding, and I think the key surprise of this entire section.
What did they find?
The analysis showed that environmental factors like passive smoke exposure, cooking without ventilation, and a previous history of chronic lung diseases were not associated with the significant independent increase in invasive lung cancer risk.
I am stopping right there. That is the most surprising finding in this entire study. For years, we've heard that passive smoke and kitchen fumes are major causes of lung cancer in Asian women. Are we saying they're not harmful?
No, absolutely not saying they aren't harmful. What we're saying is that in this specific, highly genetically predisposed cohort, those environmental exposures were not the dominant independent drivers of invasive cancer risk once you controlled for the much stronger factors, gender and family history.
The genetic signal just drowned out the environmental signal.
It was so powerful, it effectively overrode it.
And the cooking index finding was even more counterintuitive, wasn't it?
It was strange, yeah. For all participants, having a high cooking index, so that high cumulative exposure to cooking forms, actually showed a lower risk for invasive lung cancer in the analysis. The OR was 0.65.
Wait, what? Statistically, it looked like more cooking exposure was protective.
It seems completely counterintuitive, and the study authors were very quick to address this anomaly.
I would hope so.
They noted this could just be statistical noise, maybe because of a smaller number of participants cooking without proper ventilation, or maybe there's some complex interaction where people who cook a lot also have other protective lifestyle factors the model couldn't see.
So the key message isn't that cooking is good for you.
No. The key message, regardless of that strange OR, is that the intense environmental cooking exposure they hypothesized about was not confirmed as a major independent risk factor for invasive cancer in this cohort.
The signal of genetics and gender simply eclipsed everything else. That fundamentally changes how we design future risk models.
It does. And let's go back to the interaction between family history and age, because the source offers critical insight into how the disease progresses.
Okay.
They found that in participants with a family history, the detection rate for invasive lung cancer increased significantly with age. The risk was cumulative over time.
But the non-invasive cancers behave differently.
Yes, dramatically so. The rate of adenocarcinoma in situ, that non-invasive form, it remained stable with age. It didn't go up.
What does that stability suggest about the biology of these tumors?
It suggests that the non-invasive cancers are, prevalent and slow-moving, maybe growing at a glacial pace, but they are not what's driving the overall age-related risk increase. The fact that the invasive cancers are driving the age trend strongly implies a timeline of progression.
So if you leave them alone,
If these lesions are left undetected and untreated, they will progress to lethal invasive disease over a typical human lifespan. This is the biological justification for stage shifting and early screening.
and there was a specific finding about younger participants with a family history, this J-shaped curve. What did that suggest?
That curve showed a high initial peak in detection rates for invasive cancer in those under 55 years, then a dip, and then a sharp, steady increase after age 59.
So a spike in the young group.
Yes, and that early peak in the under 55 group suggests the possibility of a truly early onset, aggressive, and highly hereditary form of lung cancer, a distinct subgroup that might need screening even earlier than the official 55-year cutoff,
Especially if they have that strong family history.
particularly, as we'll see, in the maternal line.
The strength of family history is now just indisputable. But talent didn't stop at just confirming the link. They broke down the hereditary risk with incredible precision.
They did. They analyzed exactly which relative matters and how that risk manifests differently between men and women.
And that's so vital because it moves us from just general risk assessment to providing actual molecular clues about how this is transmitted.
Exactly. First, they confirmed what's called the dose-response relationship. The more first-degree relatives you have with lung cancer, the higher your individual risk.
So it's cumulative.
It's cumulative. The detection rate for invasive cancer climbs steadily from 1.6% for those with no relatives affected, all the way up to 7.2% for those with 3 or more affected relatives.
Wow. Now let's get specific. When looking at those first-degree relatives, which relationship had the biggest impact on risk?
The most significant factor was having a sibling affected. That resulted in the highest rate ratio, or RR, of 2.26.
So if your sibling had lung cancer, you were more than twice as likely to develop it yourself.
More than twice as likely, yes. Following that, having a mother affected also significantly increased risk, with an RR of 1.43.
A mother or a sibling. And what was the key finding regarding the paternal line?
This is where there's a distinct asymmetry in the data. Having a father or offspring affected showed no statistically significant increased risk for overall lung cancer in the multivariable analysis. None. This is a crucial finding that hints strongly at sex-linked or maternally inherited genetic factors driving this type of cancer.
So if we connect this to the bigger picture,
Yeah.
why? Why might a maternal or a sibling link be so much more critical than a paternal link for lung cancer in never smokers?
The researchers put forward several fascinating molecular hypotheses. Since fathers and offspring weren't significant drivers, they suggest potential links through alterations in sex chromosomes, or perhaps sex-specific hormonal factors that mediate how the tumor grows.
And there's the non-nuclear DNA component as well, right?
Absolutely. They point to the possible involvement of mitochondrial DNA.
Which is only inherited from the mother.
Exactly. Since mitochondrial DNA is inherited strictly from the mother, this could explain why a maternal link is statistically irrelevant while a paternal link is not. They also mention processes like genomic imprinting, where the expression of a gene depends entirely on which parent it was inherited from.
This moves us entirely away from generalized environmental screening toward, high-resolution genetic mapping.
It has massive implications for personalized medicine.
But let's focus on the most actionable clinical finding from all of this. The stark difference in screening eligibility based purely on gender and family history.
This is the core clinical takeaway, what we call the gender stratification of family risk. They identified a huge difference in how much familial burden was needed to qualify as high risk between men and women.
So how did that manifest for women?
For females, the hereditary risk manifested with much higher sensitivity. Women with just one first-degree relative affected had a significantly higher risk than females with no family history. Their adjusted odds ratio was 1.8 for invasive lung cancer.
So if you're a woman in this demographic and your mother or your father or your sibling had lung cancer, you are instantly high risk and should be screened. One relative is the threshold.
That is the monumental change the study proposes. One is enough, but for males, the required burden was dramatically higher.
How much higher?
The association was only significant for males who had at least 3 affected first-degree relatives.
Great.
3. The adjusted OIR for invasive lung cancer for a man with only 1 affected relative was statistically insignificant.
Wow. That means we have fundamentally changed the screening eligibility criteria for half the population based on this one finding. For a man to qualify as high risk, we need to see this massive accumulation of genetic bad luck. For a woman, it's just 1.
It's a profound gender disparity and susceptibility. It shows that genetic predisposition just manifests differently by gender in this population, and any successful screening criteria must be tailored for that.
Because if you use the male threshold for everyone,
If a health system were to use the male threshold, 3 affected relatives for the entire population, they would miss a huge number of high-risk women who would absolutely benefit from early detection.
so the overall picture of the high-risk patient in East Asia is changing from smoker with 30 pack years to a non-smoking woman over 60 with a single first-degree relative affected.
That's a complete revolution in oncology screening.
As successful as talent was at finding this early disease, we have to acknowledge the major caveat that haunts every successful screening trial: the risk of overdiagnosis. This is a crucial, nuanced discussion because we have to balance the life-saving potential of early detection with the potential for overtreatment.
The overdiagnosis concern is essential to address, especially given the type of cancers they found. We noted earlier that virtually all the diagnosed cancers were adenocarcinoma.
Right.
And the pathology breakdown showed that 44.0% of the cancers they identified were either adenocarcinoma in situ, AIS, or minimally invasive adenocarcinoma, MIA.
Can you clarify that distinction? Why does finding a lot of AIS or MIA raise the flag for overdiagnosis?
Well, overdiagnosis, simply put, means finding and treating a cancer that would never have harmed the patient within their natural lifespan.
The cancer that wouldn't have mattered.
Exactly. Think of it as a speed bump on the road of life. It's technically an abnormality, but it was never going to progress into the fast lane. AIS and MIA are the classic examples of these indolent, non-invasive cancers.
And they have a low risk of recurrence after surgery.
Very low. So finding and removing them increases the incidence rates without necessarily reducing the late-stage mortality rate. That's the definition of overdiagnosis.
So the concern is, are we subjecting high-risk individuals, mostly women with these slow-growing nodules, to unnecessary biopsies, anxiety, and eventual surgery?
That is the core question facing the researchers. However, the study provides a very strong counter-argument to this. A slow but lethal counter-argument.
Okay, what's the evidence for that?
Well, while the LDCT did detect many of those pure ground glass nodules, the classic slow growers, the pathology showed that 36.1% of the pure GGNs that were identified as lung cancer were already pathologically classified as invasive adenocarcinoma.
That's significant. So more than a third of these subtle, potentially indolent-looking lesions had already crossed the line into aggressive invasive disease.
They are definitely not harmless bystanders. They are already shifting into the fast lane of lethality.
And we can connect this back to the age trend.
We can. Let's revisit it. The fact that invasive lung cancer incidence increases significantly with age in the high-risk group, while the non-invasive incidence remains stable, that suggests that progression is the norm, not the exception, for this cohort.
If left untreated, they will eventually progress.
They will eventually progress and become lethal.
So the conclusion here is that the high detection rate is primarily achieving meaningful stage shifting, finding the cancers earlier, which is expected to reduce mortality rather than purely causing overdiagnosis.
That is the consensus view of the researchers. The stage shifting to early disease, specifically stage 1, is a massive victory. And finding them so early allows for highly effective, minimally invasive surgical procedures, which don't impair lung function significantly and mitigate the risk of unnecessary harm.
Finally, let's look at the practical application of these findings for future screening protocols, moving beyond that first year. We talked about balancing efficacy with resource management.
The future screening implications based on the follow-up data are highly encouraging for managing resources. The researchers tracked what happened after that baseline scan cleared out all the pre-existing or prevalent cancers.
What do they find?
Lung cancer incidence dropped sharply at the subsequent annual screens.
How sharp was the drop?
It went from that 2.7% detection rate at baseline all the way down to just 0.6% at year 1. And it continued to decrease in the years after.
That's a huge drop.
It's a steep drop, and it confirms that most of the cancers they detected initially were prevalent cancers. They had been slowly growing for years before the study started.
So once those prevalent cancers are detected and removed, the rate of newly developed or incident cancers drops dramatically, which suggests the short-term risk is much more manageable.
That's the implication, and this preliminary finding strongly suggests a modification to the protocol.
What's that?
For individuals who have a negative LDCT finding at baseline, the screening interval might safely be extended to every 2 years or maybe even longer.
And that's critical.
It's critical because biennial screening saves immense healthcare resources, it minimizes unnecessary radiation exposure, and it increases the feasibility of expanding the screening protocol across densely populated regions.
It transforms screening from a yearly resource drain into a targeted, risk-weighted strategy.
Exactly.
So what does this all mean? The Talent trial is not just a study, it's a manual for solving a massive public health failure that previously overlooked millions and millions of people.
It provides clear, data-backed answers about who you should screen when smoking isn't the primary driver. It fundamentally rewrites the risk profile for this entire demographic.
Let's summarize the primary takeaways for you, the learner, because these findings really demand attention.
Absolutely.
First, LDCT screening is demonstrably highly effective in detecting early-stage lung cancer among Asian never-smokers with these risk factors. It achieved detection rates 2.6% overall that are higher than those found in heavy-smoking Western cohorts.
And that extremely high negative predictive value of 99.7% confirms the reassurance of a negative scan. If you're clear, you're almost certainly clear.
Second, the strongest independent risk factors identified are female sex, more than twice the risk, older age, and family history, an OR of 1.67.
And critically, that familial risk is strongest through maternal or sibling links, while commonly cited environmental factors like passive smoke and cooking fumes were not confirmed as primary independent drivers of invasive cancer risk in this genetically susceptible cohort.
And third, risk models designed for screening eligibility must be tailored specifically for Asian populations and prioritize hereditary risk and gender. The fact that a woman only needs 1 affected first degree relative to be flagged as high risk, while men need 3, is the key clinical finding that makes future screening programs actionable and effective.
The Talent study has provided a working, safe, and highly successful framework, but the source material leaves one crucial piece of the puzzle on the table.
Right. And that leads us to our final provocative thought about the future of precision screening.
The researchers noted a limitation in their study. While Talent confirmed genetic susceptibility, it had to exclude a key environmental risk factor that has been demonstrated in other prospective trials: air pollution.
That's right. Research around the world, particularly in regions with high industrialization and traffic, has highlighted air pollution exposure as an incredibly important factor leading to lung cancer formation.
Especially lung adenocarcinoma, which is the tumor type we saw almost universally in this cohort.
So, given the confirmed high genetic risk and the unique cancer signature in never smokers, what happens when future research successfully integrates verifiable, individualized air pollution exposure data using, say, geospatial tracking or environmental monitors with these newly confirmed hereditary factors: female sex, maternal history, sibling history?
If we connect this to the bigger picture, that integration will allow health systems to move beyond broad population screening based just on ancestry toward truly personalized, risk-weighted screening.
So you could identify the woman with the maternal history who also lives next to a freeway.
Precisely. This would maximize the benefit for those at the very highest risk while efficiently managing the concerns of overdiagnosis and controlling massive healthcare costs. Integrating genetics and environment is the final frontier for precision oncology in Asia.
A truly fascinating convergence of genetics, environment, and personalized medicine. Thank you for taking this deep dive with us. We'll see you next time.